Cody Bounds. All right. So my name is Cody Bounds. I'm going to be your nurse practitioner student for today. Would you mind stating your name and date of birth for me?
Hunter Snell, March 23rd, 1998.
All right. Hunter, today we will be doing an assessment of your posterior, lateral, and anterior chest. Do I have your permission to continue with this exam?
Yes, you do.
All right, great. So we're going to start with the posterior chest. And starting on inspection, skin is warm, dry, and pink. There's no obvious vasculature indicating any kind of obstruction or heart disease. No obvious musculoskeletal deformity, scapula or even no obvious any kind of scoliosis are noted. Respirations are even, unlabored, symmetrical. AP diameter of the chest is in the 0.75 ratio. The AP diameter is less than that of the lateral. And we'll move on. We'll go ahead and move on to palpation here. So I'm going to start by feeling the musculoskeletal part of this, feeling the scapula and the spine. T-spine is rigid, and no pulsations, bulges, or masses are noted. We're going to go ahead and go to the chest expansion. Okay. Everything moves symmetrically. If it did not move symmetrically, this would be abnormal, and we would be worried about a possible disease process in one or both of the lungs. We go ahead and feel for scapular and subscapular nodes, and none were noted. If we did find any, we'd be worried about possible malignancies, and it would require a further workup. So now I'm going to go ahead and move on to feeling for some crepitus or any grating sensations. None are noted. Crepitus would be in subcutaneous emphysema, and grating sensation would be if the patient had a pleural friction rub. And now we're going to move on to tactile frenitus. So Hunter, when you feel my hands on your back, go ahead and say the words 99 for me.
99.
Okay.
99.
All right.
99.
All right.
99.
All right, perfect. Everything was felt normal on both sides. If there was any increase in this, we'd be worried about a consolidation, and any decrease in sensation, we'd be worried about some emphysema. Let's see. I'm going to go ahead and go on to the costovertebral angle. That is about the level of the 12th rib where it meets the spine. And I'm going to go ahead and percuss. Any tenderness noted with that?
No tenderness.
Okay, good. Any tenderness noted with that would indicate a kidney infection, but we have none, so we are good. So I'm going to go ahead and move on to percussion here. All right, Hunter, go ahead and lift up your arms for me. You can put your arms back down now. So everything was resonant, which is a normal finding. Any hyperresonance, we'd be worried about emphysema, and any dullness in an area, we'd be worried about some consolidations or masses. Now we're going to do something called diaphragmatic excursion. So Hunter, I'm going to have you let all your breath out for me, and then just hold it on empty. Okay, and take a big deep breath in for me and hold it while it's full. Okay, and that is about 4 centimeters. You can breathe normal now, which is normal. Normal is 3 to 5 centimeters, and if there's any abnormalities in that, we'd be worried about a disease process in one of the lungs due to the issues of the diaphragm not moving correctly. Next, we will move on to auscultation. And normally you would listen to a full respiratory cycle in all of the spots. However, to save time for this video, we will be doing a full respiratory cycle in the first 2 spots, and I will show you where my stethoscope goes. Go ahead and lift up your arms for me. Okay. All right. Next, we're going to go on to vocal resonance. We're going to start with whispered petroliloquy. In the presence of a consolidation or mass, a whispered word will seem as if the patient is talking or will be louder. And normally you would listen to all lung fields. However, again, to save time in this video for all the vocal resonance assessments, we'll be doing it in the first 2 spots. So when you feel my stethoscope on your back, go ahead and whisper the words 99 for me. 99. Okay. 99. Okay, and that was normal. It was whispered and muffled. So next we'll move on to bronchophony. Again, when they're speaking, if we're worried about a consolidation or a mass, the speaking words will be louder in that area instead of muffled. So Hunter, when you feel my stethoscope on you, say the word 99 out loud.
99.
Okay.
99.
Okay, and that was normal because it was muffled. Next, we'll be moving on to igophony, where the E vowel sound will sound like an A nasally in the presence of a consolidation or mass. Once again, we'll just be doing this in one spot, but normally you would listen to all of the lung fields. So Hunter, when you feel my stethoscope on your back, go ahead and say E for me.
E. E.
Okay, and that was normal. So we're done with the posterior part of the chest. Hunter, if I could have you turn around for me, we'll go ahead and move on to the anterior section of this exam. So again, we'll start with inspection. Skin is warm, dry, and pink. Clavicles are prominent. Sternal notch is seen, as well as the PMI. PMI is in a normal location for this patient. It's the mid-clavicular line on the left side at the 5th intercostal space. Let me go ahead and point out the cardiac spots for us. This is the aortic spot. It is the 2nd intercostal space on the right sternal border. Pulmonic, left sternal border, 2nd intercostal space. Erb's point, which is the 3rd intercostal space or 2nd pulmonic spot. 3rd intercostal space, left sternal border. Tricuspid, 4th intercostal space, left sternal border. And then the mitral on the 5th intercostal space, mid-clavicular line on the left side. So, Hunter, I'm going to go ahead and have you lay back for me. We'll go to supine position. Scoot up a little bit. We're looking for any heaves, lifts, or thrills, and none are noted. I'm going to start palpation, feeling for any abnormalities. Which I forgot to mention this earlier, no, pectus excavatum or pectus cavernatum are noted, so no major musculoskeletal abnormalities. Go ahead and palpate the PMI again at the 5th intercostal space, mid-clavicular line, and for children, it would be the 4th intercostal space, just medial to the nipple. So we'll palpate here and palpate the precordium. Okay, no lifts, heaves, or thrills were felt. I'll have you go ahead and sit back up for me again. Next, we'll move on to the auscultation part of this exam. Normally, you would listen to full cardiac cycle with the diaphragm and the bell in each of the cardiac spots. However, to save time for this video, we'll only do this in the sitting and slightly lean forward position. And I will show you where my stethoscope goes for the other 2 positions. Okay. All right, and Hunter, I'll have you lay back for me. And again, you would listen to the full cardiac cycle in each of the 5 cardiac spots. However, to save time, I'm just showing you on this one. All right, and all right, I'm gonna have you go ahead and lay on your left side in the left lateral recumbent position. All right, you can sit up. So S1 and S2 were heard. No ejection clicks or murmurs were heard, or snaps indicating any kind of disease with the heart valves. S1 is the closure of the AV valves. It's best heard at the apex, the 5th intercostal space, mid-clavicular line. S2 is the closure of the semilunar valves, which is best heard at the aortic and pulmonic spots, 2nd intercostal space, right and left sternal border. S3 was not noted. That would be rapid ventricular filling. It's best heard at the apex. And S4, which is always abnormal and needs a further workup, would be an atrial kick, forcing blood into an already dilated ventricle, but this was not heard, so this is good. And this concludes the assessment. We'll do a room scan.